Thank you, Nikos. Thank you, everyone, for asking me to speak today. So I've been asked to speak on paediatric recipient renal transplantation, the workup, how, when, and where. So as we all know, preemptive living donor renal transplantation improves the morbidity and mortality of children with end-stage kidney disease and is widely accepted as the gold standard for renal replacement therapy. So I've just pinched some slides from NHSBT just to look at paediatric kidney-only transplants in the UK since 2009, particularly looking at the differences between deceased donor and living donor, and how I think all of us are striving for a living donor transplantation. And then just another slide to look at the different units around the country and their activity. So just to talk about the GOS programme, the first living donor transplant was in 1990. Since April 2015, we've carried out 127 transplants, and that's till November 2019, 84 of those being living donor and 43 deceased donor. And these numbers include children from other centres, children in the sharing scheme, HLA incompatible and ABO incompatible transplants. We approximately have 100 recipients for workup at any time through varying degrees of CKD, and talked about 80 donors annually. As I said, we treat children from the NHS, from other centres. It says E112, but I believe that's now NHS2, and international private patients who are essential for our funding for the hospital. We deem that patients should be about 10 kilos for transplant, and it takes about 15 months, 16 months of age to get them to 10 kilos and to have received all their vaccinations. So just to look at our transplant activity since 2006, again recognising that we have more living donor transplants than deceased donor. So to look at the transplant workup for the recipient, we start with doing their blood group. Then we do their HLA typing, which we send to the clinical transplantation laboratory at Guy's, and we test their HLA antibodies. For living donor, we only do an initial cross-match with the donor if the recipient has the presence of HLA antibodies, they've had a previous transplant, or as advised by the transplantation laboratory at Guy's. And if it's going to be a donor blood group incompatible transplant, then we'll do ABO titers. All children should have received all their immunisations prior to transplant, so they'll have their routine vaccines, and then we ask them to have hepatitis B and varicella if they need it. Just to state, a recent change is that the hepatitis B vaccine is now included in the UK in the routine baby vaccines, but we're having to play catch up with those children who haven't received this, and GPs are now refusing to give their Hep B in the surgeries, so I think it's something the units are going to have to start taking on. As I said, if the children are varicella negative, we'll give them 2 varicella vaccines, and if they're measles negative following 2 MMRs, we'll give a measles booster. They should have a course of hepatitis B vaccines plus a booster, and they have antibodies greater than 100 mils per unit per mil. We check their CMV and EBV IgG, and if they're negative, we continue to check that every 3 months. And we check the Hep B and C antigen and HIV antigen to ensure they're negative. Other bloods, we do coagulation. If the coagulation is abnormal or they have a family history of bleeding or clotting disorders, we'll do a full thrombophilia screen and take advice from our haematology team. We do regular liver function tests, and if we deem there to be high risk of diabetes, we'll do a fasting glucose and an HbA1c. Looking at the imaging, we ultrasound the abdominal vessels, looking particularly at the IVC and the iliacs to ensure they're patent. It's our policy that all children under 20 kilos have an MRV, but they also have an MRV if they've had previous femoral lines, previous transplant, and if we deem there to be any occlusion or complex anatomy. We do a neck ultrasound if they've had previous neck lines. We do a yearly echo, or more frequently if they've got cardiac dysfunction. We do bladder ultrasounds to ensure the bladder is safe and empties to completion, and will it cope with the increased urine output post-transplant. And then think about, does the patient need nephrectomies prior to transplant, such as with FSGS. A lot of our children come to us from urology, so we work closely with the urology team to get a bladder plan prior to transplant. They may have a bladder fill assessment or go on to formal video urodynamics. We have an MDM. All the children are brought to MDM prior to listing for transplant, be it deceased donor or living donor. And if there's any urology problems, we invite the urologist to come along and agree a plan with us. We like to document the bladder plan, and annually the bladder plan is reviewed, or more frequently if need be. So other things, we encourage all patients to visit the dentist, to have healthy oral hygiene. An anaesthetist will review them at the MDM, but if we feel the anaesthetist needs an individual review, she will see them separately. We involve other specialities as needed, such as hepatology, cardiac or metabolic, particularly with the MMA children. Does a PICU or CICU bed need to be booked post-operatively? We book a PICU bed for any child under 20 kilos or complex problems, otherwise they come back to the ward. If it's a particularly complex child, we might ask for an extended theatre list, whereby we start the recipient before the donor. All patients must have MDT before proceeding to listing, and then the protocol signed off by the transplant consultant. We also insist that all families have psychological preparation and input prior to transplant. The psychosocial team will discuss practical aspects of transplantation, such as if one parent is a donor, that's taking one carer out of the family. If we have a single parent who's donating, does the other adult staying with the child have parental responsibility for consent post-operatively should something go wrong? They look at the care of the siblings, loss of earnings of the donor, and the impact on the whole family. And we also heavily involve our play specialist, who isn't Lindsay, Charlotte. We've got a new play specialist to help prepare the children. So nearer to the time of transplant, the family meet with the consultant transplant nephrologist in the pre-transplant clinic, and they meet with the transplant surgeon. They normally meet with the transplant surgeon more than once, and we have a weekly surgical clinic. The nurse specialists have ongoing discussions with the family, trying to prepare them for this time, and talk about the preparation and the process post-operatively, such as the follow-up, the medicines, plan for return to school, and just how difficult a time it can be initially. We then will confirm the transplant date with the lead surgeon, the family, and the ward. Once we have that date, we'll book a PICU bed if needed, email the team, book the patient hotel. If the donor's on site with us, we'll book a taxi so they can go over to Guy's early in the morning and do the final cross-match. And the patients can visit the patient hotel, the ward, and PICU if they want to. The week prior to transplant, they'll meet with the surgeon again and do the surgical consent. We'll do the final cross-match with the recipient and donor, a chest x-ray, finalise the admission plans, and then the consultant will sign off the protocol. And then all the results go to the ward. If we're activating a child on call, we just send HLA antibodies over to CTL, ensure the protocol's up to date, very similar to the living donor preparation. So we're met with many potential donors, normally in clinic. Jen and I will be the first port of call for them. So we'll take a basic medical history, ask if there's a history of diabetes, hypertension, talk about BMI, and then we'll register the donor with us. We'll do the blood group and the tissue type. And particularly when we do the HLA typing, we always explain what the test is, so we don't receive any nasty surprises, which you then may have to explain. We give them their transplant information pack, and we'll then refer them over to Anita, our counterpart at Guy's. If it's an overseas donor, we'll get the blood group done locally and either get the HLA typing done locally, but in some countries it's very expensive and the families can't afford this. So we get them to bleed them locally and send the bloods over. And they often do get lost in the post, but we usually get there in the end. Once we refer the donors over to Guy's, we make it very clear the donor must make contact themselves and book their appointment, so there can be no coercion on our part at all. And then all the donor work up thereafter is done at Guy's. We keep that very separate. so that, again, there's no coercion. We liaise very closely with Anita at Guy's. We hand over, I would say, weekly, sometimes daily. And then the donor will have thorough medical and psychological assessment comprising initial discussion, the medical tests, bloods, ultrasound, GFR, CT, echo, ECG, and sometimes have to proceed to flexible cystoscopy and biopsy, meet with the nephrologist and the transplant surgeon. Once all this is okay and they've gone through MDM, the independent assessment we booked, where both donor and recipient and a representative of the recipient attends. So we always look at our service, we always try to make improvements, we continually audit our practice. We'll do a morbidity and mortality meeting for a death or an unexpected patient outcome. We constantly look at our preemptive rates because we aim for living donor preemptive transplant, and we look at whether any patients on dialysis who could have received a preemptive transplant and didn't, or are there any delays or barriers to listing on deceased donor transplant list. And also, are there any barriers to living donation, for example, fear, financial issues, or psychosocial issues that we can help the families with? As I've mentioned, we get referred complex out-of-centre and overseas recipients, regularly referred to us mainly from Scotland, Wales, Ireland, Europe, and the Middle East. The complexities of these children can include surgical challenges, comorbidities, complex urology, and particularly MMA. And just to mention, we've started an MMA collaborative network incorporating Great Ormond Street, King's, Guy's and St Thomas's, and Evelina. And each case brings its own challenges, both surgical, medical, and geographical. And there's an added dimension of another team in there that can sometimes lead to some communication difficulties and some delays. So I just thought I'd talk about the way forward. So firstly, to mention the National Living Donor Sharing Scheme, which I'm sure you've all heard of and all aware of. It was quarterly national runs, managed by NHSPT. And the scheme includes paired and pooled donation, where donor and recipient pairs are either HLA or ABO incompatible. 2 pairs is paired donation, more than 2 pairs is pooled donation, and an algorithm is used to match and maximise the pairs. Some families are very reluctant to consider the sharing scheme, so we have to spend some time sitting with them, explaining to them, and letting them know the very, very positive outcomes from this scheme. Also, in the paediatric population, we put limits on with the sharing scheme, such as age and mismatch. And we have to be aware that this can reduce the chances of being matched. So I think it's very important to assess each child individually, weighing up the risk. We get many calls from altruistic donors. So it's an anonymous, non-directed altruistic donor to a recipient on the waiting list. They can be registered into the sharing scheme and can start an altruistic chain. As I said, we get quite a few phone calls from people phoning up saying we would like to be a non-directed altruistic donor, and we direct them to the NHSBT website explaining how they should register for this. We've been doing some blood group incompatible transplants, which is transplantation across the blood group barrier. Before we proceed with this, we would advise a minimum of 3 runs in the sharing scheme first, and then we'll consider ABOI if the ABO titers are low. If we proceed, we draw up an individualised plan with the team regarding immunosuppression and is there a need for plasma exchange, double filtration, plasmapheresis, or immunoabsorption. We've also done some HLA incompatible transplants, and this is transplantation when the recipient antibodies are present against donor HLA. We could take advice from the clinical transplantation scientists, nephrologists, and the adult surgical team, read the tailor-made immunosuppression protocol. And again, it's risk versus benefit. Is it riskier to leave a child on long-term dialysis with no chance of transplantation, or to proceed with a HLA-I with increased immunosuppression? So just very quickly, HLA matching. Historically, we've always accepted a 1-1-1 mismatch for living donor and a 1-1-0 for deceased donor. With the children on call for deceased donation, after a year, we reduce their criteria to **1 = 3. So that means we'll accept a 1 or 2 antigen mismatch on the A or B, but only 1 on the DR, but it still equates to a 3 antigen match. With living donation, we're looking more at accepting 2 antigen matches from a fit, healthy donor after discussion with the team and the family. And with deceased donation, if the child proves difficult to match or has very limited dialysis access, which we're seeing more and more with people returning from transplant, we're enlisting initially for a star 1 equals 3. And social media campaigns, I think, is the biggest change that we're seeing. It's becoming increasingly popular. The HTA state it is not illegal to advertise for an organ as long as there is no offer of reward, payment or material advantage, and this can incorporate directed altruistic donation. We've had 1 child who's successfully transplanted from a social media campaign, and we have another donor who's just been referred to Guy's for one of our children, again through a social media campaign. It's a lot of work because you get a lot of donors that come to you initially, maybe 10, 20 for 1 child. And lastly, our best initiative is we've started a theatre open day with the cardiac team, and every 3 months we invite children and their families to come to theatre where they can dress up as a surgeon, they can scrub, they can pretend to stitch, cannulate, play with the surgical instruments, and the feedback from this day has been fantastic. 1 child went down for a transplant a week after her open day, and she said it just relieved her anxiety hugely. Thank you.
Thank you very much, Maria, for a very thorough and clear talk. I would like to ask you if you have any questions or comments. We also want to hear what you do in your units. It's a great opportunity in this meeting to do that.
Thanks so much. Great talk. What proportion of your patients, or how many HLA-I incompatible transplants have you done, and what type of patients are you doing the HLA incompatibles in?
I might direct that to 3. Thank you. Yes, we've done 3 HLA-I. Sorry, what was the second part of your question?
Why are you doing them? What's the reason? Are they overseas patients?
No, they're in-centre patients. We take advice from CTL as to whether it's high risk or historically positive. Do you want to answer, Nizam? Do you want to speak?
Yeah, one of them was from Ireland and had been in the sharing scheme unsuccessfully. I think it's, as Maria said, it's a balance of risk versus benefit. If they're running out of access, if we think an HLA incompatible transplant is relatively straightforward, and we'll risk assess them in a number of ways. And if the alternatives are limited, so if they're very highly sensitized and therefore their chance either in the sharing scheme or on the deceased donor list is limited, then we will consider it. But it's not that common, and on the adult side, we've seen the number of HLA incompatible transplants falling quite dramatically.
What do you call an HLA incompatible?
We would define that as someone whose baseline cross-match is positive. So a DSA positive, cross-match negative, we're not too concerned about. We think that's okay. Give them some slightly stronger immunosuppression, normally Campath. But an HLA incompatible is someone who has a positive cross-match.
Is this a historical or a present?
Current.
Current. Okay. Now, do you use complement fixation to see if this cross-match positive has complement fixation?
So we don't typically test for C1q antibodies, if that's what you're driving at. C4.
Yeah, C1q. Sorry.
C1q. My understanding is that the evidence about whether or not C1q is a risk factor is variable. There have been some studies suggesting that if you have C1q positive antibodies, you're at increased risk, but equally some saying that that's not true. So we have looked in our paediatric population. I don't think Livy is here because she did the work, but I don't think she found any correlation.
Thank you. And I'll show you some slides later on about the number of incompatible transplants that we have done. Thanks.
I just wanted to ask from Leeds how you deal with those social media campaigns. We've just had one recently and had 500 inquiries in the first couple of days.
Well, luckily we haven't had 500, but we have quite a lot. And what we do is ask them to provide their blood group. And if they're blood group compatible, then we'll do HLA. And then if they're
So how do you choose which ones? Because
the ones who are, well, out of the 20 that we've had, only one was blood group compatible
Right,
with a
okay.
3 antigen match. So that sort of weeded it out. And then we put a stop on it. So after about 20 or 30, if we've got
Yeah.
1 or 2 potential donors, we just take their details and say, we have enough, we'll deal with what we've got, and
Yeah.
then we'll contact you later. Because it's so
Yeah.
time consuming.
Just eliminated the waiting list. Well done.
We try.
It's a very interesting question and point. I'm on the council for the British Association for Paediatric Nephrology, and it's something that we're discussing because it actually varies hugely. Even though there's only 13 paediatric nephrology centres, of which 10 do transplantation, some centres have a policy where basically they give out the number for the ward. And there was one centre, which I won't mention any names, but as you said, basically the phone lines just didn't stop. So there's a feeling that we'll say that we'll probably only look at the first 10 that come forward and then do it in runs of 10. But obviously we direct people to NHSBT because if MD wants to be an altruistic donor, then they're still able to, whether it's directed or non-directed. So we would want to encourage people coming forward to not use it as a negativity. So we had one patient who was on ITN News, and literally there was 100 phone calls to ITN, which happened after that.
Yeah, so we developed an appeal website. We've learned from a previous case, so we've devised an appeal website, which this family that recently went on the news locally and stuff, they gave out this appeal website, so all the potential donors were emailing that, so it didn't take our phone calls out of the way, but yeah, there was 500 inquiries. Out of that, 50 have returned to health questionnaire.
That's good.
So yeah, it's just then how do you move forward with, and hopefully we'll have a lot of altruistic donors from it who aren't compatible. But
Thank you. Thank you very much, Maria. Oh, one more question, sorry.
What do you do with family that don't want vaccination for their children? Will you transplant
We don't
them?
proceed to transplant.